Well, good morning, everyone. Just tell me if you hear me well in the back. Okay, great. I'll try to not move my head all my body. Okay, so thank you for the invitation. I really appreciate it, and I'm so happy to meet you all here in Penn that I never visited before. I'm going to start by telling from Emilie how sorry she is to not be able to come. She is here, very close, but she had a very bad news for her family, and she really is not able to talk at the moment. So I'll have to skip her slides because she was starting the talk normally, and we hadn't time to reorganize, but I'll do my best. It means you're gonna have only part of the story of what we're doing at Eden about that topic of work health inequalities. I'll take more time to present what I wanted to tell you, so I'll speak slower, which is there because I'm a fast speaker, both in French and English. And also we have more time then to discuss and have Q&A session at the end. And of course, we will provide more information on Emmanuel's work and Emmanuel's work after through email, for instance. So I'm an epidemiologist by training, and I was an associate professor of epidemiology and biostats in the French School of Public Health from 2010 to 2018. Then I joined INED as a tenured researcher, and I've been working for a long time now with my colleagues in social sciences to disentangle different aspects of social inequalities in health, and in particular in work-related social inequalities in health. So I'm going to present some hints of what drove us to start now to really work together with the demographics of epidemiology and other colleagues in other disciplines around these topics of work, health, inequalities, and how we tend to develop a life course approach to produce new knowledge about it. So the outline, I'm going to skip, unfortunately, the first part that was exciting about the new insights into social and occupational inequalities in healthy aging based on the French data we have and on Emmanuel's and other colleagues' work. And I will move directly to the other part that I wanted to introduce, like the quantification of work-related social inequalities in life expectancy that mixes demographic methods and epidemiologic methods. Through a methodological proof of concept. We'll take from that. And finally, I'll introduce, but in a few words, our new project, which is called Work It for Work Health Inequalities, that is aiming at maintaining health selection and social prevention in explaining these occupational class disparities we see through a life course approach based on French record linkage data. So sorry, I'm going to skip slides very quickly. Close your eyes. And there were lots of animations because she's so good at it. Here is what you're missing. Actually, I'm so sorry you missed it. Basically, Manuel is working with different sources of data. She's using the vital statistics in France, and she's also using ad hoc longitudinal cohorts that are shared with university teams. But now I'm going to move to a work we are now publishing in the American Journal of Epidemiology with my PhD student I'm working with, Ardis Gouloubi, and a colleague at the Maryland School of Public Health, Mary Beth Terry. And it's about quantifying work-related social inequalities in life expectancy and for the development of methodological concepts. So the background, I think you know a lot of it already, but in addition to being closely linked to education, household income availability and lifestyle or health behaviors, occupational class encompasses both employment relations and workplace hazards, or working conditions. Therefore, work has been integrated within models of social determinants of health for a while now, acknowledging that employment and working conditions have powerful effects on health and health equity in particular. So explaining part of disparities in health and mortality at the population level. Accordingly, the extent to which occupation-based mortality should be seen as reflecting living and working conditions or individual choices and way of life has been a matter of debate since at least the late 18th, the mid-19th century. Sorry. And moreover, over the last, well, the second half of the 20th century and early 21st century, we had more and more prospective research to believe that occupational risk factors mitigate to a certain extent the effect of socioeconomic status on health and mortality. However, the reduction in social disparities in mortality that could be achieved by modifying employment and working conditions has been understudied compared to lifestyle factors in general. So lifestyle factors like smoking, dietary habits, alcohol consumption, exercising, and the like. Only about one study in the US conducted by Joel Go and colleagues at the Harvard Business School at that time, who proposed a model-based approach and estimated that 10 to 38% of the difference in life expectancy across demographic groups defined based on their ethnicity and gender could be explained by exposure to harmful workplace practices. And they took into account a range of 10 different workplace factors. We do not have any other study published so far, and in particular in France, this kind of information is lacking so far. So the objective of our research was here to quantify the contribution of occupational risk factors to social occupational inequalities in life expectancy in France. And more specifically, we aimed at extending existing formula-based methodologies to estimate work-related occupational inequalities in life expectancy based on a feasible attributable risk approach rather than running model-based estimates. So the attributable risk approach, it's an approach stemming from epidemiology. Attributable risk was developed back in the 1950s by epidemiologists such as Levin and Dahl, they did it as a new tool to inform decision makers about the dangers of smoking at the population level. So it was a health impact measure developed at that time specifically to counter the active strategies from the tobacco industry to delay the time when the level of evidence would be found high enough to take action against smoking at a national level. And then over the last, the end of the last century and now forward, it has been more and more used in public health to rank different risk factors against each other, up to the Global Burden of Disease project that uses it intensively. And so this is this kind of approach we are using here in the present work. And we chose this, well, so the aim is to extend these formula-based methodologies rather than running model-based estimates that rely on a large set of hypotheses that are usually hard to check on. Of course, we wanted to test it through a proof of concept study first, based on the available French data, meaning that we don't have definite figures to provide. They must be taken with caution in the end because it's a proof of concept. And we also aimed at identifying at the same time the data and knowledge gaps and knowledge needs to conduct the approach with greater accuracy and future integration of work into health methods. So I'm going to go through this, starting by the analytical approach we developed, going through 4 different steps. So in step number 1, so it's really where epidemiology contributes, we estimated the proportion of all-cause death attributed to non-occupational risk factors through the population attributable fraction or attributable to risk approach, the PATH approach. Then in step number 2, we use demographic tools, precisely life tables available from the French Institute of Statistics to derive both death rates and life expectancy at different ages. in the French population. And by crossing these two sets of information, the paths, so the proportion of death attributed to non-occupational risk factors with these life tables, we could assess the years of life loss attributed to these non-occupational risk factors. We did so each time we computed all these metrics, both by sex and occupational class, which I will further refer to as super-occupational group, because it matches more the way the French system of coding occupation is built, but that reflects on occupational class anyway. And in the final step, we then computed the proportion of life expectancy gap that could be attributed to non-occupational risk factors based on the previous steps. So you see, it's really epidemiology, social epidemiology, and demography working together to improve awareness and how the disparities is built. So in the first step, the first task was to select risk factors and their meta-related risks. So when we're looking at how much the risk of death is increased by a specific risk factor, we are deriving these relative risk metrics that you know well about. And then to make the most of all the available evidence, we use meta-analysis in epidemiology. So we need the meta-related risk because we are stronger, more robust than single studies related risks. So this is what we sought for in the literature, and we found good quality meta-analysis for only 4 occupational risk factors, namely no job control, job insecurity, unemployment, and occupational physical activity, which was found to be significantly increasing the risk of death only in men. Then the second step was to assess the prevalence of exposure to these different risk factors by the same social demographic groups, sex and social occupational group, occupations class. And to do that, we used the SIP, Santé Itinéraire Professionnelle, which is an occupational trajectory survey documenting work histories on a representative sample of the French population, and also documents some self-reported health outcomes that we didn't use. And it documents also a range of work conditions factors at different points in time over the career. And so we use the standard formula that we have to assess these population table fraction for each risk factor and for each group of sex and occupational class. And we further estimated the joint path for the total attributable fraction, combining the 4 risk factors together, again by sex and social occupational group, and using the delta method to derive a 95% confidence intervals. So I'm just summarizing what we found. The results are presented by social occupational group or occupational class. And so I'm only reporting here the joint path among men and among women. So in bold, I highlighted the lowest and highest joint path each time. So for men, the lowest path was quite expectedly found in senior executive professionals and professors, which are the most highly educated and higher income group, occupational group. And the highest joint path was found in manual workers. Whereas for women, the lowest joint path was found for agricultural workers, and the highest again in manual workers.
I have a question. Is there any group that has 0? What are the units?
It's the proportion of death attributed to these risk factors. It's the principle of the population attributable fraction is to say what is the proportion of cases of a disease or deaths that can be attributed to some known causal risk factor.
I understood. I will understand that if the mean is 0, but if the mean is 15,
the minimum is 0. The maximum is 100% for each risk factor. It's the average across the SOC, a group, a social occupational group.
Somebody who doesn't work will have 0.
No, we have confidence intervals. There is no one with 0. Well, yes, there are people who were not exposed to the risk factor within each group. but it's based on the prevalence of exposure to the risk factor in each group. It's based on the formula, the first formula here, here is expressing the population attributable fraction is normally estimated directly from differences in incidence in exposed and unexposed in the population, but we never have this information in the general population. So instead, we use this formula that was set in the 50s and that is extensively used in public health, where you combine the prevalence of exposure to the risk factor with the relative risk of the outcome, be it death or any health outcome, to derive the proportion of cases, the proportion of people who suffered this particular health condition or death ultimately, that can be attributed to this risk factor. And an important thing, and sorry because it's a specific tool in public health and epidemiology, but the paths for the different risk factors do not sum up to 100% because there is overlap in exposure between different risk factors. And in the framework of multiple causality, where it's never a single risk factor that causes a disease, it's a combination of different conditions that must be met for the disease onset to start. Then you can have overlap between different factors that explain both. You can have a lung cancer both due to asbestos and smoking at the same time.
Are these differences between social groups entirely explained by differences in prevalences, or do you are the risk ratios also?
That's a very good point, and that's one of the limitations we highlight at the end is that we usually don't have relative risk specific to each social group. So at best, we have it for men and women separately, which is totally necessary. But the ideal thing would be to have it for each social occupational group. But again, you need such a large amount of data to do it that usually it's not available. So it's the average relative risk across all SOCs. And what makes the difference is definitely the exposure prevalence. So the assumption behind is that whatever your social group, the increase in risk that you're exposed to the drug control will be the same, which is of course, simplifying assumptions. Okay, so this was the first step, and of course we had the population attributable fraction for each risk factor taken separately. Before we combine them to a formula that acknowledges for this certain amount of overlap between the factors. But that was not the result we wanted to highlight here. The second step you do it by heart. It's estimating life expectancies at different ages. So I just report here life expectancies at 35 years, estimating their 95% confidence intervals and doing it by sex and occupation class. So this is what we find, and this is exactly the same results as INSEE, which provided our National Institute of Statistics, which provided the data found. So we just reproduced their results here. There's nothing original. Then there is a gap, of course, in life expectancy at 35, both between men and women, which is already, and also between different occupational classes or social occupational groups. For instance, in men, the gap between senior executive professionals and professors that are usually considered as the reference top level in terms of life expectancy, and the manual workers is 6.3 years in men at that period, which was stemming from 2009 and 2013. Sorry for not mentioning it earlier. And in women, the gap is smaller, although still 3.3 years at that time. So this is something basic. But then in the third step, we are using the joint path to estimate adjusted death rates. And then it means that we are trying to guess what would have been the death rates if we had removed all these exposures from the population. So we are making this counterfactual scenario that there would be no exposure at all to these different risk factors. And we try to infer how much mortality would have been reduced, and of course, reduced differentially in different sex and social groups, because the amount of exposure to start with was not the same. So we do it, and we estimate this adjusted life expectancy under the counterfactual scenario of minimal exposure to the risk factors. Just to mention that about this counterfactual scenario, there are many different approaches. The simplest and first approach we use usually is that there is no exposure at all. But we know, of course, that it's not possible to remove all of the exposure from the population. So this theoretical minimum level can then be better informed if you have external source of data, helping deciding what would be a reasonable amount of reduction in exposure, and then you can build scenarios as to what the impact will be in terms of public health outcome. But we took the first scenario, like with zero exposure, as a first step in this proof of concept, which can be improved later. Sorry. So in blue, you have the same life expectancies at 35 as before, which was based on observed death from the INSEE life tables. And in red, you have this counterfactual life expectancies under the scenario of minimal exposure to these 4 risk factors. And you see, of course, that under these scenarios, life expectancy would have been longer in every occupational group. And then we can, based on that, both look at what would be the years of life loss due to the 4 risk factors within each social occupational group. For instance, we see that in the manual workers, there will be 3.1 year of life loss due to these risk factors. And we also, and in women, it's 1.9 years. And we can also, of course, calculate this new gap in life expectancy. So it will be a gap in adjusted life expectancy that is now taking a different amount. It's now, for instance, between senior executive professors and the workers dropped to 4.4 years, whereas it was 6.3 years before in observed life, real life data. And it drops also from 3.3 to 2.2 years in women. Now, the final step is to estimate the attributable gap, which is the percentage of life expectancy gap here at 35 years that is attributed to occupational physical activity, low job control, job insecurity, and unemployment under the theoretical minimum risk level counterfactual scenario of compared to no exposure at all. So it's just the difference between the 2 gaps in life expectancies expressed in terms of percentage of original gap. And so the summary results are here. So here we just put again the difference or gap in life expectancy at 35 in each SOX and sex group. We also report, so it's the first column, delta, oops. I'm left-handed, sometimes it has consequences. I cannot go backward. I'm trying to go backward.
Yeah.
Yeah. Yeah, I don't know if it's good. Yeah. Sorry. So I was trying to point, it didn't work. I'm pointing here and there. So this is just the observed gap in life expectancy at 35 in each sex and subgroup. This is the adjusted gap based on the counterfactual scenario that there would be no such exposure in the workplace as those we selected based on literature. And here it's the attributable gap, the third column here, that tells us how much of the gap has been attributed by this method to the selected risk factors. And we see that it goes in men from 22% to 30%. And in women, it's more varying. It can be negative in the former group. And it's up to, again, 31% in manual workers. And it's basically explaining a similar amount both in men and women in that case. So about the discussion of these results. So according to the literature and that we translate into these estimations, we see employment and working conditions are contributed actually substantially to the association between occupation class and mortality in France. Since a combination of only 4 occupational risk factors could be as detrimental for health equity as the well-known lifestyle risk factors quantified earlier by colleagues across different countries, who in that case had looked at, as I mentioned earlier, tobacco smoking, physical activity, alcohol drinking, fruit and vegetable consumptions, and overweight, I think, overweight capacity. But of course, these results are subject to both over and underestimation bias due to the underlying assumptions that we had to make and the paucity of adequate epidemiologic and population-based data in some cases. For instance, there were a few occupational risk factors that we could include due to large data gaps in the literature about the association between occupational risk factors and all-cause mortality. Usually these occupational cohorts are industry-specific, they focus on a specific risk factor, and so now there is a growing number of population-wide cohorts that look at psychosocial risk factors and much broader definitions of work organization factors, etc., and not only the chemical, like physical and biological factors, or even ergonomic factors that have been extensively studied. But we have much fewer population-based cohorts than we do have industry sector cohorts, so hence the gap. And also they usually focus on this one specific health outcome, like cancer, rather than overall health and overall mortality. The other thing is that the calculations are based on point prevalence of exposure, with an equal coverage of socio-occupational groups. For instance, in our SIP survey, a French survey that we use to estimate the prevalence of exposure to these workplace factors, we had about 12,000 people. So if you split it by sex and SOG, of course, it makes the estimate less precise, so wider confidence intervals, introducing more uncertainty in the estimations. And in many cases, that could be more relevant to have access to lifelong prevalence of exposure, depending on the timing of the effect that is usually not so well known. We can have also positive and negative confounding and interactions that cannot be taken into account in the past calculations. And of course, the timing of the past needs to be more nuanced in terms of age groups to consider. For instance, we could expand the approach by calculating partial life expectancy, like stopping at age 80, to avoid immortal bias, for instance. But we need adequate knowledge each time to make these decisions. And often the adequate knowledge is not there. So as a conclusion, we think the one advantage of this methodology based on the formula, well-known formula of attributed interactions, is that it's transparent and it could be expanded as more data are made available. We summarized here the data needs and knowledge to expand on it. So as I mentioned, we need more studies documenting all-cause mortality related risk to have stronger data-related risk for more known occupational risk factors. We didn't find it for many occupational risk factors because, as I said, we have many studies focused on short-term or cause-specific outcomes and not mortality overall. We have some studies which report cause-specific and not all-cause mortality. And we have less occupational cohorts interested in occupational risk factors that are based on the population at large. There may be also an equal coverage of women workers because there has been a large gender bias into occupational epidemiology that has been documented. I have documented it in occupational cancer research, occupational epidemiology related to cancer research, but it has been shown in other areas of research too. It's improving, but still we're lying a bit behind. There is also heterogeneity in the definition and measurement of exposures and confounders, and the estimates are usually based on the assumption that periodic risks have lifelong implications. That's the same for any behavioral risk factors. We have the same problem with occupational risk factors, but that's an assumption we must make clear in the approach. So the meta-relative risks are usually more robust, but they may be less portable to the target population because we mix findings from, in general, North America and different countries in Europe, and we apply it to the French context, which might be different in terms of public health and employment or labor market policies. And also, usually these meta-related risks are not available by social demographic groups, as you rightly so it's Michelle. And so, of course, that makes the assumption that it's homogeneous between the social groups questionable. The other thing is about estimating the prevalence of exposure adequately. We often have point prevalence of exposure instead of lifelong exposure assessed, because it needs to have career-wide information that not only documents occupation or job title, but also content of job, or to use external sources of data to impute an average most probable level of exposure to that specific occupation in a specific sector at a specific period in time, which is not widely available. We also have the same problem as for meta-related risk. We can have the social demographic groups that are not adequately covered. And we can also have some mismatch in the definition of exposure between how it's defined in the studies, documenting the meta-related risk, and how we can document it in terms of prevalence of exposure. So we have the timeline issue already pointed, like point versus lifelong prevalence. And in addition to it, using an appropriate lag between the exposure and the outcome, because most of the exposures do not exert immediate effects, and they have chronic effects exerting over a certain period. Cancer is typical of it. You had a minimal lag for every solid cancer of 10 years on average. So you cannot just take exposure now and risk starting from now. You must apply this lag. We also have sometimes different exposure measurement tools to further working conditions. And the reference level also, so the lower exposure level can be defined differently. And moving back to the step of calculating the paths and the joint paths from the standard formula, as we highlighted, it's difficult to take confounding into account because we have two different sources of data combined within the formula. It's difficult to account for overlap in interactions between the risk factors because the joint paths assumes independence between risk factors, and they also may not be estimated by adequate social demographic groups depending on the availability of input data. And finally, when we combine these two sets of metrics, we have some knowledge that we still need to choose the right timing, like the lag between exposure and life table data, the age range to avoid immortal time bias. And it means that we have a large gathering and computational effort to estimate also the variance and 95 confidence intervals in these metrics. However, this work is really based on a unidirectional vision of the relationship between work and health. So we're really in the framework of what I've just presented, look at the occupational gradient as explained partly, of course, through employment and working conditions that occurred before the health deteriorated up to death. But in the world of social disparities in health, we of course know that we have different processes operating at the same time. We have social causation at large. So the first part of it highly well documented in different sociological works. It's across the life course, how your parental socioeconomic resources will influence your educational attainment, which in turn will influence occupation and income in adulthood, in working ages, and then retirement and income at that time of your life. But we also have this other type of social and occupational causation by which you're being employed or not, and the type of job and the type of working conditions you have will influence or cause your health to be either protected or impaired. And that's really what occupational epidemiology and occupational health produces as knowledge extensively also. But we also have this health selection process that is operating over the life course, by which to be able to contribute to the labor markets, you need to be fit enough, and the ability to start working, the ability to retain a job, and the ability to work long will largely depend on your health status and how it changes over time. This is something that is accounted for in occupational epidemiology as the healthy worker bias. And there are different ways to try to overcome it, but it's never possible to remove it completely. But here, the interesting is to look at it as a dynamic process that plays together with the social occupational causation processes and trying to get a more nuanced and precise picture of how these occupational gradients occur dynamically over time. So to do so, we need to integrate literature and conceptual frameworks from the social determinants of health world, from occupational health, which is a technical and complex field to grasp, and also, of course, the life course approaches that have been developed at the intersection between sociology, demography, and social epidemiology. We also need then to have the adequate data to work them out. We need multidimensional data linking social and economical dimensions across the life course, or at least a reasonable period over the life course, but also health information that could be strongly reflecting the health status of individuals. We need them to be longitudinal, to look at things dynamically, so as much as possible, and if possible, to be representative of the population at large, and not to miss importance for any subgroup of the population that is important. So recently,
Could you go? So I'm really happy about this last slide because you get. So this is not a criticism of what you've done because you've mimicked, you followed the literature. But as I look at this, what it seems to me is that this is kind of the graveyard of these old sociological concepts. Sociologists for years imagined, and I'm not, that there was social class and social status, Marx, Weber, and so on. And, even in the French literature, if you go back, this whole socioeconomic groups, and I know it's all official, it all comes from this thing that parallels the US, which was people trying to define some kind of social class and social status that was not exactly the same thing as your income, occupation, and education. So back in the day when I started, we would code married women as having the class of their husbands.
Yeah,
and things
sure.
like that.
Yeah, absolutely.
And that was an idea. But since, as you correctly point out, in the dynamic model, occupation as opposed to this dying idea of social class or social status, is somewhere in the middle of the whole thing. It sort of suggests that trying to decompose changes in something in the middle, it's got this, it seems to be holding on to something from a failed sociological past because.
I don't think everyone would agree that it's a failed sociological past, but I'm not a sociologist, so I will leave sociologists to answer that question.
What is the in other words,
what's your question?
Well, my question would be, for example, if you come up with 30%, I would say, and I'm not an economist, but I would say, well, come on, control for income and education, and how much is there left to explain in the first
Sure,
place?
but there is collinearity in it, so it's a mediation, it's a pathway.
Right,
it's one of the pathways.
Right, but what is the variance we're trying to explain? Is it between literally the occupation, what people do when they go to work or get in front of their computer in the morning? Or is it something about something like their social status and social
That's
class.
precisely that. We start from observing there are differences between socioeconomic position, social class, whatever you call it, and there are so many ways to capture it. And this is sociology.
Yeah, but it depends
very
what
good.
the antecedent
And then
of it
we're
is.
looking at intermediate factors such as lifestyle is also an intermediate factor, the same as workplace factors are. So, and workplace factors also influence health behaviors, by the way. If you're working night shifts, you won't have the same dietary pattern at all or sleep patterns at all that people who don't.
Okay, so that's
yeah.
great. I
that's
totally agree. I
intermediate.
totally agree with you. So now here's the criticism. You shouldn't call it the occupational gradient. You should call it the socioeconomic
Yeah.
status gradient
I
because
agree.
because
I
we're
agree.
not
That would be more specific.
specifically taught.
Yes.
There's
I get the
kind of
point.
funny illusion of
You
occupation.
make the point. I agree.
Okay.
Yeah, totally. That could be more the occupational class gradient in that case. It would be really specific of what
Right,
was
if
in
it
before.
really exists, yeah.
Yeah. Well, the data say it exists. In terms of if you use occupational class to
I
locate
was
people
taught
on
it
the
existed.
social
I
space.
believe it, but
Yeah.
I'm just
Yeah.
saying.
Okay. So now I was just saying that we need the relevant data to do so. And fortunately, look at the sparkles in my eyes. In France, we have good news that finally researchers will be able to access a source of data that has always been inaccessible to us, linking extensive information about socioeconomic positions, status, conditions, etc. over the life course, or not over the life course, over a certain period, at least longitudinally. We have consumption data that come from the health insurance system, and namely, that is about hospitalization, refunded medication use, any consultation to the medical doctor, and also, of course, the medical costs of care. So around this new opportunity of accepting a large representative sample of multidimensional longitudinal data, our team at INED, at the Mortality, Health and Epidemiology Research Unit, a team of 5 researchers, and I'm coordinating the project. So it's namely Florent Bonnet, Giancarlo Camada, Emmanuel Courtois, myself, and Anne Guzman. We have gathered to make this new project the WorkFit project for work health inequalities, aiming at disentangling the health selection and social causation process in occupational class disparities through a life course approach based on this French record linkage data. We also have associated researchers. We have a colleague who is professor of sociology, Emilie at Paris Dauphine University, an expert in ignorance studies in occupational health. Ophélie Merville, who is a postdoctoral researcher in social epidemiology at INSERM in Toulouse, and Olof Östergren, who is an associate professor of public health at the Stockholm University. And we also gathered a scientific advisory board with Véronique Duval-Tourde, a sociologist specialized in occupational health in the School of Public Health in Rennes, Elodie Giroux, who is professor of the philosophy of medicine and science at the Lyon 5 University, and who is especially interested in how epidemiologic paradigms change the way we produce knowledge into public health. And Pekka Matikainen, who we have already know, a professor of demography at the University of Helsinki. So in this project, we really want to take advantage of this new source of data. It's called EDP Santé, EDP Health. So EDP is for the permanent demographic sample, which is a sample of people born over now 16 days each year, followed up passively, prospectively through the documentation of the administrative data. And it's now, as I said, linked to the health data hub data, health consumption data. And it makes up a sample of 3.6 million people living in France, including overseas territories except Mayotte. So more specifically, here's the timeline of the currently available edition of the sample, because we hope it will be updated regularly to expand the whole period. But so far in the permanent demographic sample, we have data from civil registries, from the census, from the all employees panel that is a wealth of information that each year employers have to report on each employee in terms of their occupational title, the amount of time, the working time, the amount of salary, the activity sector, etc. And we also have had more recently access to tax data. And now it's linked to the National Health Data System, so ambulatory and community care data, hospitalizations, causes of deaths, and what we call the mapping of conditions, which is a set of algorithms set by the health insurance to locate precisely based on health consumption who is likely to have developed a certain condition, like a specific cancer, like diabetes mellitus, to like any kind of condition. So there is now more than 50 conditions that can be located through these validated algorithms, which makes it a powerful tool to look at specific health outcomes. Of course, we have vital status too, and of course, we have medical causes of death too. So we can look at mortality quite extensively to the limit that it's only 3.6 billion people. So, yeah, sure.
Your mortality data, you can get mortality from 68 to the end
Yes.
because of the civil registry that would record deaths.
Yes,
not just cause of
correct.
death.
Really birth, death, marriage,
Yeah, right.
So
That's
we
not
have
the
the
cause
vital
of death.
status from here. Yes, we do have the vital status. We already had it within EDP. So there was a lot of work, and Emmanuel, I think, was about to present some of the previous work about the work trajectory already, the trend into occupational trajectory and mortality risk overall, irrespective of the medical cause of death. Yeah. But now the news is that we can add the medical causes of death and some insight into health as measured through health consumption, which of course has its own limitations. And so it's going to be a very dense wrap-up of what we intend to do, but I'll be glad to discuss it further with you. So within this Work Health Inequalities project, we have 3 different aims based on specific hypotheses, of course, and relying on a set of different methods, interdisciplinary projects, obviously. So the first aim, and that's Emmanuel leading the subgroup here, is to measure changes in life expectancy and disability-free life expectancy as a function of sex and occupational class in France, and to look at trends as much as data are available longitudinally, and further to identify the contributing conditions and causes of death to explain these differences between sex and occupational class groups. The hypothesis is that certain work-related conditions like disabling injuries, musculoskeletal and mental disorders could significantly impact trends among the younger generations due to changes in participation in the labor market and working conditions. So it's really a demographic module of the project using the usual modeling approaches to life expectancies and external sources of data also to derive the disability-free life expectancies. To have external information on activity limitation by the same sex and occupational class groups, namely the EU share and the French autonomy surveys, and further an attribution model to disentangle the different medical causes or conditions that are contributing to these gaps into disability-free life expectancies and life expectancies overall. The second aim is then to move to explaining these patterns, these sex and occupational class patterns, and explaining the mechanisms of unfolding, particularly in adulthood. And so, as we said earlier, we aim at studying the relative importance of health selection and causation through social causation or occupational causation in adulthood. The hypothesis here is that we observe erosion of wages and working conditions in the low end of the labor market, notably the development of the non-standard forms of employment, even in France, like the self-employed, we don't have really the 0-hour contract thing in France, but it really, there is, for younger people, a very drastic change in the labor market situation. And we also have, conversely, an uneven access to work after disease or injury, depending on social position and resources. That could worsen these inequalities if we look at things dynamically. So it's a module that is more a social epidemiological module, where we're going to focus on empirical case studies. We cannot embrace health in a global way. We're going to look at different case studies to develop a method and then try to expand it on other case studies. The first one is about disabling work accidents that are obviously related to work and that also obviously impact the ability to work after. So we find it a good entry to set the whole theoretical model and empirical approach. And the second one will be a more touchy one, I think, because it will deal with mental health in relation to occupational trajectory. And of course, that will require to look at specific mental health issues as we can locate them through the algorithms in the health consumption data. We'll use methods widely known in demography and quantitative sociology, like sequence analysis, to assess the trajectories of work before and after the health outcome occurs, and using sometimes also as a first step, like unidirectional model of time event modeling approaches that are very usual. But we also intend to use these more advanced cross-lag panel modeling that do not make an a priori assumption about the direction of the association, whether it's from work to health or from health to work, and that dynamically assess what is more likely the direction of the total hour, let's say. And thirdly, and I think importantly, and I'm really keen on that part of the project too, because it's another line of research I didn't mention before, but I'm also very interested in it, in the production of ignorance in occupational health when we use certain approaches in epidemiology. And I did a qualitative research on how using the behavioral risk approach could create blind spots in what we know about occupational health and its impact on health disparities. So the final aim will be to clarify the potential and limitations of these linked medical administrative data to advance scientific knowledge in these fields. The hypothesis is that the secondary analysis of administrative data may create blind spots for specific subgroups, particularly those who are not covered well because they are underserved, and administrative data rely on what we document, also based on benefits that people receive socially and economically. And here the methods will build more on ignorance studies, that is the STS approach, social science and technology studies. We did it already for the population attributable fraction project, where we worked with my colleague Emilie. So here we'll do some observatory participation into documenting data analysis thoroughly, prospectively, documenting each time we would have liked to have some information and we didn't get it, documenting precisely what section of the population we could document and what section we couldn't document, or what dimension we could capture well, such as in France, we would have the possibility with this data to define migration backgrounds, but not ethnicity or radicalization, for instance. This data would allow that. We will, of course, analyze metadata, documenting the data, everything that is provided by the Data Hub and the other sources we can see. And we will conduct interviews with data producers, of course, to understand better what ends up in the data and what is dropped. Finally, I was longer. I thought I had plenty of time, so I spoke a lot, and I hope we still have some time for questions and answers.
We had some discussion already, but we have 3 minutes left for any questions that people may have.
So this is a very impressive project, related probably to Herb's question. Is there consideration or is there a way of integrating selection into occupations or examining that as part of this big project?
Yeah, that's precisely the aim of looking at the health selection, direction of, so we're gonna look, of course, at what we have as information as health status prior to hire, but that will narrow down our sample size because we will have a shorter follow-up because the health data, I showed the timeline, they are available only from 2008, I think. Well, some of them. So we have much less follow-up. We have maximum of 13 years of follow-up for them. So if you want to start to look at the trajectories based on the initial health profile and how it could have impacted how the employment trajectory unfolds after, that reduces, of course, the possibilities. But yeah, we will do that, and with the cross-stack model also. But we will never have the full, maybe to answer better your question, we'll never have the full life trajectory starting at when people finish school, finish training, even vocational training. What were their health status at that time, for instance, and how it influenced their entry to the labor market? It will be a small sample we can look at it because it will be the younger generation we have, as we only have like maximum 13 years of follow-up. Yeah.
Yes, so very impressive. I have a question. I work in parts of the world where the informal labor market is really big.
Yeah.
So, and where using administrative data to account for that part, we would miss a lot. So I wonder if that's the case, if your data captures that and what your thoughts are about including that.
Yeah, absolutely. So that is exactly the point with the third part of it. Because as I said, well, the first, and I said that I had sparkles in my eyes, but I also know that like illegal workers won't be registered as workers. They will be in civil registry, but we won't have records of their work anyway. So, or people who just arrived in France and don't have their legal documents yet. Undocumented migrants also will be not these sources. So, and that's only those we think of easily, but I'm sure there are some other blind spots we have no idea of. For instance, also if you look at the available data here, I mentioned we have this all employees panel, which is good for salaried workers. But for self-employed, we would rely only on the census data, which are much less expensive, and they are so there would be less good quality. However, I hope I can add a line soon because there will be a non-employee panel that is supposed to be added soon, but I don't know exactly what's in it and how it's documented. But that's a process going on. So that would mean we could, but so far I cannot say I will be able to document well the work trajectory of non-salaried workers. That's for sure.
Okay, well, we're running out of time, so thank you.